right.
You all must forgive me in advance. Excuse me.
Hey, no worries. Well, we got a quick introduction from me. I just want to go ahead and say good afternoon to everyone. Thanks for joining what will be our last webinar of 2020. Thanks for joining us. We've been on this road together, providing information and exchanging information since April. So I want to first of all thank Keiko, who's behind the scenes, who always gets everything done. And then Mia Keys, future Dr. Mia Keys, for always sort of providing, for leading these conversations. I couldn't do it. So I'm so glad that she's here and thoughtful and can do it. I'm glad to end this with Dr. Sharfstein, who's going to talk about the future of public health. He's a professor at Johns Hopkins. Well, I'll let Mia go into his bio and whatnot, but I just want to go ahead and last time say thank you. And I look forward to this conversation today.
Brandon, I'm absolutely looking forward to the convo. And what I was going to say right before we pressed record was, please forgive me in advance. My little pup is feeling particularly needy today. So he's like right here. And, if for whatever reason I'm looking down, I promise I'm listening. He's just being a little whiny. So I just want to make sure that he's okay. I think all of us are maybe feeling the way that he might be feeling in some ways. So I'm grateful for everyone's presence. I'm really excited to have this conversation today with Dr. Scharstein, and we're going to be essentially talking about the role of public health in today's world. And by today's world, I'm referring particularly to the season of COVID, but even beyond that, just any crisis situation. And so Dr. Scharstein joins us as a professor of practice in health policy and management from Johns Hopkins, where he's specifically at the Bloomberg School of Public Health. And he serves there as the director of the American Health Initiative, as well as Vice Dean for Public Health Practice and Community Engagement. And this is certainly in addition to so many other things that he's currently doing. And most recently, he served as a senior advisor to the Biden-Harris campaign, and we'll talk a little bit about that. But prior to all of these roles, Dr. Scharstein served as the secretary of the Maryland Department of Health and Mental Hygiene, as the principal deputy commissioner there, as the principal deputy commissioner to the FDA, as well as commissioner of health in Baltimore City, which is where he resides with his wife and 2 children. He's also recently written a book, which I can't wait to get into. It's certainly very relevant to the moment. The book is titled The Public Health Crisis Survival Guide, Leadership and Management in Trying Times. And he's also the co-author of another book called The Opioid Epidemic, What Everyone Needs to Know. And both books are published through Oxford University Press. Very excited to have you joining us here today, Josh. I'm wondering if you can first and foremost, just tell us how you are. How are you?
I'm doing fine, thanks. Thank you. I am in my basement Zoom room here. Sometimes I'm joined by my dog, but not at the moment. So it's good to see you, and thank you for having me. I should clarify, though, that I don't think anybody would describe me as a senior advisor to the Biden-Harris campaign, but I was an advisor at times.
An advisor. Okay, I appreciate that. Well, we will still honor the fact that you were very, very critical in having leadership's ear and not taking that that position for granted. I'm wondering, what does that mean to what did that mean in addition to everything else that you're doing or you had been doing at that time? What did the day-to-day entail in terms of being an advisor? And you volunteered as well, so there's also.
I was a volunteer, really.
Yeah.
I was a volunteer, and occasionally I would get questions that I could jump into and help. I had the chance to brief I guess candidate Biden and Dr. Biden about school reopenings during COVID. Mm-hmm. So that was obviously a pretty difficult, challenging issue, remains a difficult, challenging issue. So, I was mainly, though, just watching from the outside as it all happened with everybody else.
Yeah, as the sage that you are, that certainly goes quite well. It segues into what we'll be talking about today in terms of leadership, right? And management of crisis situations. I'm wondering foremost, before we delve into the heart of the conversation, if we can talk a little bit about the distinction between public health and the health care system in the U.S. What are the intersections? What are the differences? And then as just a follow-up question, what has this season needed with respect to each sector? What have we needed from the public health space? What have we needed from the traditional clinical?
Sure. That's a great question. In the United States, the public health system and the healthcare system are pretty separate. You know, I think of healthcare as delivering patient care as its primary focus. We're talking about hospitals, physicians' offices, clinics, emergency departments, really focused primarily on individuals. And to the extent that they're focused on groups, it's groups of patients. That's sort of the main focus of the healthcare system. The public health system has a different orientation. It's really about the overall health of the community, generally defined geographically. Public health is what we do collectively as a society to ensure the conditions where people can be healthy. That's the Institute of Medicine's definition. So it ranges from certain functions of assessing community health to environmental health to policies and to other like kind of core functions. Restaurant inspections, for example, are a public health function, not really a healthcare function. And for many years in the United States, those were really quite different. When I'm teaching about this, I sometimes use the example of cholera in London, when there was one of the first epidemiologists figured out that there was a cluster of cases of cholera. And, based on that information, the local hospital instituted a clinical practice guideline for diarrhea. No, that's not actually what happened. Sometimes people think like, well, if you see a cluster of cases, well, what's the healthcare answer to that? Maybe that would have been a clinical pathway. But of course, it's a famous case of John Snow. And what he did was he took the handle off the pump. It was an environmental intervention. So in public health, we're thinking about much more than just the one-on-one patient encounter. It's about what's the settings, what's the environment, what's the policies that allow for a community to become healthier. Now, just the last thing I'd say is, when you have a challenge like COVID-19, you really need public health and healthcare to work together. In the United States, healthcare is a lot stronger than public health. We have, I think, 97 cents or so on the dollar goes to healthcare and 3 cents goes to public health. Public health departments are not the ones with the beautiful, foyers and magnificent buildings. They're generally run down and sparsely, staffed, and they've lost a lot of staff in recent years. And I think we've seen some of those challenges play out with the COVID response in different areas. But we also have examples of where public health and healthcare have come together. Healthcare to take care of patients with COVID, public health to prevent people from getting COVID in all kinds of different ways.
Yeah, I really appreciate that. All of those vivid examples about what healthcare is compared to what public health is, where each show up and where they continue to need to show up in terms of taking an opportunity to recognize areas of cohesion. It's really interesting in my own career over time. So with respect to, I am a public health person. I'm a third-year doctoral student actually in public health policy and management at GW.
Great.
And I also, but I work for the American Medical Association, right? So I am a public health person operating in this very healthcare space, through the Center for Health Equity. And I can see all the time where existing tensions are, but I can also see how, to your point, this moment really does call for clarity in terms of who has to be at the table to thwart oncoming threats to our public's health. And COVID is not the last, and certainly to your point earlier, it's not been the first.
And maybe we should talk about that, where equity sits at that interesting junction between public health and healthcare. Our healthcare system, as I think everybody knows, is not known for its equity, frankly. There's differential access. There is differential quality of care. There are all kinds of challenges that people particularly from low income and minority communities face in the healthcare system, issues of trust. And so you have a crisis like this, and there's a lot of data on this that, testing went to areas that maybe weren't the areas that you would want testing to go based on the prevalence of the disease. There were a lot more cases of COVID in low income minority communities, and, an enormously higher rate of hospitalization and death. And but the healthcare system kind of maintains its focus on its usual customers in a way. I mean, that's at least the momentum that it has. And so the healthcare systems had to do things differently, or would need to do things differently, in order to address some of the equity challenges of COVID. And that's kind of where public health has come in. It's public health that sets up mobile testing in communities that don't normally have good access to testing or diagnostics. It's public health that might set up a call center like they did in Baltimore for anyone to call, even if they don't have a doctor, to figure out what, what they should do or whether they should go to the hospital. It's public health that sets up, in coordination with healthcare, ways to have fair access to therapeutics like these antibody treatments. In Baltimore, there's like a single standard and everybody gets referred to one place rather than, these stories of people calling up, hospital presidents to try to figure out how they can get themselves the treatment. So in a way, I think of a critical role of public health is to look at the big picture, look at the health of the population, thinking about particularly populations that are disadvantaged in different ways and trying to get the healthcare system to deliver for them in a crisis.
I want to jump off exactly right there, right? So you're talking about these places where public health shows up and shows up with really with the not the expectation so much, but really invited into the clinical space, especially in times of crises, right? But I want to know, after the crisis moment passes, right? And we're in an enduring crisis state right now, right? But after this moment passes, do you envision where public health has shown up and been invited to reside within the clinical space, within traditional healthcare? Will that remain the case? Will that be the flow moving forward, or do you envision we will
I tell you, and this is part of my class on crisis, in my book on crisis, is that there's an enormous push to go back to normal in quotes, after a crisis. That happens with every crisis. And it's just, okay, phew, we're done with that. Now back to what we were doing before. That is just this enormous push. And crisis leadership is really about getting people to see the crisis as a point of change, and a point to do things differently. And in fact, you need to do things differently if you're not going to have the same problems happen again. So how could that play out? And I think it's really important for people to keep an eye on these things. And in my book and in the course, I go through all these examples from history. In some cases, crises led to major transformations. In other cases, almost none. And I think the difference really is about the moment and whether people really take the moment to push for change. It doesn't sort of automatically happen. What could that look like here? I think one area relates to community health workers. I think there's a general appreciation in this moment that contact tracing and other key public health functions are going to go much better if you have people who are trusted in community to do the work. And there are a lot of places that are hiring people. Do those people all get fired when we're done? Or do you develop a core of public health workers that can be shared between public health departments and healthcare systems to really help people stay connected to the healthcare system, to get people with high blood pressure into treatment, other things outside of just COVID? Can we keep that workforce around? That's a really good example of a change that could make a difference, including for equity, if we can stick with it after the pandemic ends.
I couldn't agree more with you, right? About pretty much everything that you said there, especially about this moment in time, this window, right? How do we really galvanize or leverage the core tenets of public health such that this moment does not just dissipate? It becomes the norm. It becomes the movement. And to your point about really having to show up at different sites, right? So in the process, you mentioned contact tracers, right? You mentioned having interventions at certain points, but public health calls for us to move things a bit more upstream in terms of our interventions, and that's how we start to normalize the presence of public health within crises, right? So I'm thinking about the former president of the American Public Health Association, Dr. Kamara Jones, has at this point, pretty well-known graphic that she describes as, the state of healthcare, right? And what it looks like is health is on a cliff, right? And so it's like a little cliff. I'm wondering if Keiko can actually find it and put it in the chat for people to refer to. But essentially, it's this cliff, right? And at the bottom of the cliff sits an ambulance, right? And the ambulance represents tertiary care, or it represents emergency care. It represents usually where people get in terms of healthcare and receiving some need. Right above the this ambulance is a net, right? And that's just, that net right there is described as a safety net. It's the catch-all that helps to keep people from falling into deep sickness, which is called by the ambulance, right? And then on top, like right at the very edge of the cliff, there's also another barrier that's supposed to signify, that last stop before falling into to need, right? And then there are groups of people some who are situated very close to the cliff and in danger of falling off and falling into and needing. And then there are others who sit further back from the cliff and they are out of danger. And from an equitable standpoint, they tend to be those who have access to those public health preventative tools that keep them well, whether it be living in spaces where they have access to fresh fruit and water at a affordable rate, secure, safe housing, green spaces, and so on and like that. How do we get to a point where we're not operating any longer at that tertiary space, and
right.
we are?
Well, I think I'm familiar with that graphic, and it's obviously with Dr. Jones and her leadership. I think that something to appreciate is the further back you go, the harder the politics gets.
Yes.
Like, so if you're saying, let's buy more ventilators, everyone wants to buy more ventilators. That's easy. Then you go back to, up to, we want to keep community health workers around. Well, community health workers, they do a lot of prevention, but it's also a little bit further downstream than other things, But I think very important to have that level, to have that function in the healthcare system, to be more accessible for people and more effective. But like you point out, we want to go even further up. I think we may have trouble keeping the community health workers from a political standpoint, but that's a really important thing to fight for. Then you go further up and you say, we need to end homelessness. I was on a call with some mayors and they said, like, this is a moment for us to take advantage, in other words, of this discussion, like how unhealthy homelessness is, how expensive it is. Let's figure out ways to really push on housing and homelessness. That would be an example of going even a little bit further upstream. We have a crisis in food access, just astronomical rates of food insecurity. How do we use this to really fundamentally change the discussion around food? Very, very important. I would say two things. It gets harder, but more important the further up you go. But also, I think that winning the battles along the way can get you momentum to go further up. Sometimes I think there's a little bit of like, it's either A or B. And let's not talk about community health workers. Let's only talk about ending homelessness, But I tend to think of it that you can get momentum from doing some things that really do matter, but are a little further downstream. You just can't forget that that's not the end of the story. You have to be able to keep pushing up, and you have to use the momentum you get and the fact that you can deliver the things you say are going to happen, that you're able to be effective. And that gives people confidence that as you get to these thornier, more difficult things, for all kinds of reasons, more difficult politically, that you're able to push through those barriers too. So that's my view. I think people may have different perspectives on that, but I'm willing to take a success at any level, even if you buy more ventilators and you save some lives there. I think that's, it can be quite a necessary thing to do if you're thinking about where we are now in California, for example. But you can't just think that's the end. You have to be using those successes, leveraging them to be able to move further up and move people further away from the cliff.
I want to stick with what you were just saying about, the further up in the cliff you get, the harder the politics become, right? And to your point about recognizing those wins that give us momentum, that's also in a lot of ways the democratic process of being bipartisan. Those wins occur within a political season, right? So how then are we thinking about public health in a political sense? And how can we recognize and analyze this moment, especially now that we're transitioning into another administration? There are changes also occurring at the congressional level, at the local levels. How should we think about that?
Well, I think we have to be honest and say this hasn't been the greatest moment for public health politically. We have so many health officials. One of my friends just had, his family harassed. so many people have been fired, belittled, armed protest on their front lawns, insulted, attacked online in really nasty ways. Just, it hasn't been a moment where people have rallied behind the field of public health. And there are a number of reasons for that. I think some of them, I think, are the quite cynical idea that, we could play off public health in a way. Let's describe public health as the meanies who want to shut things down, and we'll be the brave freedom fighters who open things up. And so there were sort of narratives that were created about public health which really fed into this. And it also relates just to the incredible polarization, I think, of our times. But in order to really have momentum on these things, I think we're going to have to come to a new understanding of what we think of as public health and how public health is important. And I don't know how easy that's going to be. I mean, I think that is in fact part of the challenge to getting to some of these solutions in a divided country like we have now, is to find some areas of common ground and develop coalitions to get different things to happen. Like, it is quite possible, I could imagine, a new kind of agricultural public health coalition around food insecurity coming together. People in America shouldn't be hungry. Children shouldn't go hungry. It's a different kind of understanding, and it might be a little bit different than like, are we, what's the latest order from public health that is going to get people upset? Let's try to shift that conversation over time the best we can. But there are some fundamental challenges, and I think it would be hard to be wildly optimistic about the fate of this discussion. I think people across the healthcare system are going to need to be supportive. And I do think that I'll just, to our overall theme of healthcare and public health, I think this is a moment for healthcare to really be a friend to public health and to be joining with public health on some of these really important and fundamental questions for health.
Yeah, I couldn't agree more with you. And I want to pick up with several things that you mentioned. One of them is, where do you start? Where do you start the change, right? Are you, and you serve as the dean, as one of the deans at Hopkins, Johns Hopkins. I'm wondering, what does it mean in terms of medical education to really muddy the waters about what healthcare engagement ought to look like and needs to look like moving forward with respect to public health and developing either physicians or other providers who value public health and public health practitioners who understand healthcare? What does that need to look like on the medical education front?
Well, it's a good question. I think the diversity of the student body is extremely important. We've just done very poorly as a country in that regard. And I think it really needs to be a higher priority, frankly, for medical schools. I think there may be some tiny signs of progress in different ways, but overall, I think that's extremely important. And I think it also relates to the curriculum.
Yep.
One of the first courses at Hopkins that the students take, I teach in, because I'm at the public health school, not the medical school,
right.
But they bring me over to the public health school, and to the medical school, I mean. And we do a whole section on social causes of disease. It's led by Dr. Thornton, who's fantastic. I give a talk on the different ways that physicians can have impact from healthcare to public health. And so I think that kind of training is very important. And over time, I think, it's just important. And another thing that I think is important is learning in teams. And we've just started something at Hopkins where we have hundreds of medical students with nursing students, pharmacy students, and social work students do case-based learning around the overdose crisis. And they talk about a case from their various vantage points. And we actually have public health students in that discussion. And so, I think there's both like the diversity of the student body, the actual didactic classes, and kind of the more experiential learning that is really important to help people see this. Ultimately, though, I think the institutions in healthcare have to be oriented to the overall health of their community. And I do think that there's some positive signs there, but a lot more room to grow.
For sure, because I think what we do see, to your point about healthcare systems moving to a space where they're valuing the community, we see some hospitals, for instance, erecting food banks within their hospitals, right? Or expanding their social services units such that the social service workers might be able to let the physicians know or providers know that this person is experiencing homelessness. So they might need connections to secure housing or things related to Uber, the company Uber partnering with some hospitals to get their patients to, you know, their visits, their ongoing visits. You know, how do we make it so that that's not I mean, these are innovative responses, but we need some normalization.
You want those to be the rule, not the exception. I think, I'll tell you of an interesting project that we're working on that is related to this. A few years ago, I did a project with a medical resident where we looked at all of the hospital awards in the country. Like
the awards.
The awards, like US News and World Report and, you know, et cetera. And essentially, they really only gave lip service to community health. It was a lot about the quality of care delivered within the hospital and patient satisfaction. But whether they were contributing to the health of their overall community really was either no points whatsoever or a very small number of points with some vague language. And we published that paper, I think, in the American Journal of Public Health. And subsequent to that, we heard from IBM Watson, which is a top 100 hospitals awards program. And we talked to them and they said they were interested in developing a new kind of measure to include in their ranking. So in addition to their usual rankings, they would have something that had to do with community health with a focus on equity. And so we put together a draft measure and we put it out for public comment in this fall. We've got over 750 discrete pieces of comment from over 100 commenters. And we're working to finalize our proposal to IBM, which they may then adopt. I'll put the link in the chat if people are interested in just seeing what we proposed. But it had a lot to do with making some of these things standard. We called it the best practice standards. They're not just best practices, but best practice standards. And you know, getting involved in the food system, that was one of them. We want to see, you know, the opportunity for hospitals to get involved in housing in different ways. That doesn't have to be offering housing, buying an apartment building, but it could be supporting low-income housing in different ways to help create more housing in their communities. And, you know, this is just sort of version 1.0, so you'll see some weaknesses to what we did, but it is exactly along those lines that we felt very strongly. There are a couple like awards that are standalone awards for like, you know, good community service hospitals. We didn't want that. We want this to be part of what a definition of a good hospital is. It's not just quality care inside your hospital, but it's actually helping to keep your community healthy in different ways. And so I was very impressed with the hospital community. They gave us a whole bunch of ideas. We're revising this proposal that I'll share right now, but I think that this is a direction for healthcare to think about, which is that everyone has a responsibility for community health. It's just not enough to sit in your own, you know, within your own kind of world and not realize how there are these really important issues that are fundamental to whether or not we're going to be in a society that's getting healthier.
First of all, that's excellent work. And yes, please share that the link to the write-up with us. And I will remind people, if you have questions, please drop them in the Q&A and certainly keep the chatter going in the chat. The other thing I want to ask you about with respect to what you just mentioned is, you know, so a lot of times providers might push back or hospitals might push back and say, well, it's not our role to do X, Y, and Z. It's not our role to have, it's our role to take care of the body. It's not necessarily our job to do anything outside of the walls of the hospital, right?
That's exactly what some of them said in our public comment period. So yes, you're exactly right.
Mm-hmm. So, I mean, what's the retort with that? You know, and walk us through the process of, to your earlier point about coalition building, because coalition building also entails working through those tensions, really teasing out those differences of opinions. What's that process like, and how do you help to convert people?
Well, I think it's important to see big picture here in the United States. We spend a lot of money on healthcare, way more than every other country in the world on a per capita basis. Mm-hmm. And not only do we have generally poor outcomes, we fall into the bottom in life expectancy in our kind of group of countries. We have just, shocking disparities by race and ethnicity. Some groups are actually losing ground in life expectancy based on where they are. So we're basically paying a lot and not getting a lot of health for it. And this is a fundamental crisis for the healthcare system. We need to, if we're going to pay this kind of money, we need to get more for our health. We need to be walking around healthier. When I was the health commissioner of Baltimore City, there was an interesting report that was put out about Washington, D.C. by the RAND Corporation. And it showed that they had very high rates of preventable admissions. And I read that report and it kind of opened my eyes to the idea like, wow, there's this concept of preventable admissions. Like, it's important not just to take care of people when they're sick, but to try to prevent the admissions. And, I understood that at some level in public health, but that you could measure it. But the other thing that struck my eye was that in order to do that report for Washington, D.C., they needed to get all the data from Maryland because of a lot of Washington, D.C. patients went to Maryland. I should say the third thing that struck me about that report is that I recognized the name of the author as someone I was pretty sure I went to elementary school with.
Wow.
So I called her up and I said, I bet you have all the Maryland data. And she said, yes. And after we reminisced about elementary school.
Sure thing.
And then I said, how much would it cost for you to run the data for Maryland and for Baltimore in particular? Because I'm the health commissioner of Baltimore. And I think they probably charged DC $1 million to put it all together. But for us, it was like the marginal cost was like $50,000. So I got a foundation to pay the money. And we got a report for Baltimore, much higher rates of preventable admission. And we released the report. And, I basically said something to the effect of, look, if you're really sick with a terrible asthma attack, Baltimore hospitals will take great care of you. But if you want to avoid getting an asthma attack, then maybe Baltimore is not the right city for you. We have an awful lot of preventable asthma here. And if you just think of the hospital as just sitting there waiting for some, poor child to come in, gasping for air, that is a very cramped view of what healthcare can do, because there's a lot that healthcare can do to prevent directly and indirectly kids from having that kind of crisis. And so we should see if what we're trying to, and we're spend so much money on healthcare. If we're going to spend that kind of money, then healthcare should be thinking, we want fewer children to be, getting critically ill from asthma. We want fewer kids to be lead poisoned. We want fewer kids to be injured, and we will organize our services around that. And, the other component of this, not only, so first of all, that it's important, that it's possible, and that it's being done. I mean, you have some great examples. DC Children's has a phenomenal asthma follow-up program that just dramatically reduced the number of readmissions for asthma. There are all kinds of great examples of what hospitals can do. And the fun part of putting that report together is that we got to put in all these examples. So I think the field is waking up. There are some people who have this view like, we'll just stick to the hospital and just see who shows up in the emergency room. But I think that view is actually fading a bit. And there's so many examples of hospitals that are excited to lean forward into community health. We want to give them recognition, support, and, more standards to be able to do that well.
Yeah, even before COVID, for sure, that's been the case. And now since COVID, I agree, we're definitely seeing an uptick in health systems, not even just trying to decide what to do, but reflecting on the fact that there are things that they could have done in the past and they have not been, and they've not necessarily been primed for this moment, but now they're willing and ready to go forward. I'm going to put this munchkin down for a moment because he's getting.
Okay.
But so I want to continue with this line of conversation and talk a little bit about more than what hospitals have seen themselves traditionally doing, and now we do see people moving more into the socially determined space. What about with respect to the role of hospitals building on or giving voice to those issues that are really structurally racist in form, right? So I'll give an example of what I have seen recently. The America's Essential Hospitals just came out with a informatics brief that talks about the role of hospitals in combating structural racism, right? And I'm first of all, I thought that this was such an incredible effort, and it's just going to, I imagine, just really galvanize other hospitals outside of essential hospitals, outside of disproportionate share hospitals, to consider the same questions, right? And maybe help to push a greater consensus or coalition building between hospitals and local cities. I mean, you're coming from Baltimore, and when I think about Baltimore and I think about the health of its residents, you just gave us prime examples with respect to children's asthma, and you talked about homelessness. I can think about lead abatement in houses and the structural violence associated with living in those homes. Like we can talk about Freddie Gray and what he grew up with, and with lead in his home, and then eventually dying at the gun as a result of mishandling with respect to police. Like how does all of this converge? Where do hospitals fall? Not just with respect to talking about transportation, food banks, but really engaging in these hard conversations such as structural racism.
Well, I think that's a great question. And I think the issue of structural racism crosses between what goes on inside a hospital and what's happening outside the hospital. So, hospitals need to think about things like their payment policies, their wages, the diversity of their staff, the diversity of their leadership. There are issues there that are very much about that frankly affect everything. They affect our school of public health, affect your school of public health, that affects every institution needs to really think through this and what they can do to be much more a part of the solution rather than a part of the problem. And then you have the broader social forces that are driving structural racism. The issues of schools and access to quality schools being a big one for children. And these are really, really challenging. And I think healthcare needs to be aware in the first instance and a partner to solve some of these challenges. I'll give you an example, and I'll put another link. I fixed the one link, but I'll show something else that we did. I'll put this one in here. There was a group of people at Johns Hopkins, the School of Education, the Pediatrics Department, the School of Public Health, and we got involved in looking at the conditions of school buildings in Baltimore City. At a moment when there was a big debate with the state about how much should be spent for fixing buildings. And what we found was that I think there were hundreds of thousands of days of missed school because of the conditions of school buildings in Baltimore City. And it was far more, it appeared, than any other part of the state. And the schools in Baltimore were far more likely to be in worse condition and poor condition than other school districts in the state. And, at the same time that some of the leadership of the state was saying, we're spending too much in Baltimore, you could see that the Baltimore infrastructure was just so much worse, and the kids were directly suffering from it, and it was affecting the quality of the environment. We got the logs of different calls that were coming in for heating systems, cooling systems, how hard it was to teach kids. Those are structural issues. It absolutely tracks with race and class in Maryland, kids who are stuck in those conditions. And it really requires fundamental change to be able to improve things. And, things are moving a little bit in the right direction, but they could be moving much faster in the right direction in Maryland. And in fact, there was legislation that the governor vetoed that I think would have been very helpful for reducing inequality in education. And, we were trying to do a little bit of help for that, but I think that kind of engagement over time is going to be important. It starts with people recognizing the fundamental inequities that are there, and then realizing, look, if we care about a healthier population, we have to have equity in education for kids. I mean, that is a core element of a healthier population. You cannot expect populations to be of equal health if you're seeing just dramatically different access to opportunities when they're children.
Yeah, you hit the nail on the head with that. And I think that brings us to a question that one of our audience members asked, basically saying, what advice would you give to people who particularly come from institutions that are world-class institutions. They're highly educated. How do you get people, in your experience as deputy commissioner of health, being in USDA, being in academic spaces, being in high policy, how do you help to give advice to people who know what they know or don't, I guess what I'm trying to ask is, how do you communicate the value of equity to people who think that they know and therefore may not necessarily want to know more, or the value of public health?
Right. Well, I think it's sometimes what I say, but oftentimes it's what, other people say who have a lot of credibility and experience talking about the challenges that are being faced. We talk, it's very important to think about partnering with communities that have been disadvantaged by many of the factors that we're talking about, and have people from those communities be the teachers of critical points like that. What does it actually mean for people? So people can really understand at a much more intuitive level than just seeing statistics or hearing from, professors. And so, we do a lot of service-based learning, critical service learning at the School of Public Health. That's a big emphasis. And we're now taking a whole, just different look at where we can better involve people who have firsthand experience of all kinds of different issues in teaching. I think that really complements, it opens people's eyes to some of the injustices that have happened and are happening. But, it's a combination. And I do think that there's the that level of just direct engagement, and then there's the more, distanced, but in a way also very important look at policy to see, well, what policies are really underlying some of those issues. And so the solutions aren't always, small community efforts. Sometimes the solutions are bigger policies, and we have to really understand those policies and how they intersect. I'll give you an example. I think, healthcare payment policy is very important. And I think that, fee for service, where you get paid for every sick kid who comes in with a preventable asthma attack, isn't that helpful if the goal is to prevent the asthma attacks. And when we switched in Maryland to global budgeting, where the hospitals get paid in advance, regardless of how many patients come in, that's a little bit of a oversimplification, but the principle is definitely that. One of the first things that happened is we saw a hospital in Western Maryland take over the school health system. There was a dispute between the school system and the health department. All the nurses got fired and everyone's like, what's going to happen? And the hospital stepped up and hired them all. And I called the CEO, who was a traditional hospital CEO, and I said, well, why are you doing this? And he said, well, we're paid differently. Every time a kid comes in with asthma, that costs us because we have a global budget. So we figure we can run the school health program at break even, really focus on childhood asthma, and we can save money when kids don't get sick. And, I hung up the phone. It made perfect sense to me. And I just thought, how is it that virtually every other hospital in the country is paid more when kids get critically ill from a preventable disease? And, really rethinking the basis of hospital payment and healthcare payment in general to align with health, I think is something that the healthcare system is much more interested in now and has a lot of potential. It is a fundamental driver of the orientation of the healthcare system to some of these issues that we're talking about.
And I'm really looking forward to seeing how this is going to play out on in the next administration with our influx of leaders in the public health space, and particularly amongst leadership in CMS, right? Because this is also a CMS conversation, and the way that our national healthcare systems show up beyond, like you said, value-based care, that also matters. Before we move too far away from this topic, I wanted to also elevate a question that came from the audience with respect to the efficacy of community health impact assessments, right? So you mentioned that one of the things that you do within Hopkins is try to get people closer to issues by getting them closer to the people who are experiencing the issues through community learning and service-based learning. What about a more distanced, impact assessment? what's your take on efficiency with that?
So let me just double check. Do you mean like the
Health
community
needs
health
assessment.
needs assessments?
Yeah.
Okay.
And then how
Yeah, I have mixed view on this. I'll be honest with you.
Yeah, me too.
And I'll tell you, I once, when I was working as the health secretary of Maryland, had a hospital or somebody call me about a hospital program that was done kind of as part of its community needs work, community benefit work, where they were sending ultrasonographers to churches. And as people left the church, they were offered a chance to get a neck ultrasound and referred to surgery if it looked like they had a stenosis. The problem being that asymptomatic stenosis is not necessarily an indication for surgery and actually can just increase mortality. So, you know, we referred to that as the no vascular surgeon left behind program, but it was not good for community health. And we called the hospital and they stopped it, you know. And I just think that in a fee-for-service environment, there is a potential for the community health work to be kind of marketing by another means, a way of filling the beds by another means, like that kind of program. And that's why I think of community health work and community health needs assessments and all that work as much more effective if the fundamental alignment is there between the healthcare system and community health. And that's why I like value-based payment efforts where, you know, somebody can say, you know, what we should be thinking about our community health work is helping us achieve our value-based payment outcomes, which are better health for the community, and not have it as like two different ships passing in the night. I remember kind of an aha moment that one of our CEOs in Maryland had when we switched the basis of hospital payment, because, you know, we basically said, if you can prevent admissions, you get to keep the difference. And so they were like, you know, that's a big different financial incentive. And she said she went to two meetings. One was the finance meeting where they were talking about building another wing of the hospital. It was sort of a very traditional way of thinking about growing revenue. And the other meeting was their community benefits meeting. And she sat there and she said a light bulb went off over her head that, like, actually the community benefits meeting could make her more money than the other meeting, you know, because she now has different financial incentives. So I think that from my perspective, we should marry, and I don't want to paint everything with a broad brush, because there's certainly some hospitals that are very mission driven and they're doing great things through their community benefit plans. But I think even in those hospitals, the full commitment and resources that may be available will grow if the hospital has more of an alignment itself in its core financial orientation with the health of its community. And I think that that's a way to think about solving some of the challenges in healthcare with costs going out of control, with some of the challenges in health with, you know, really inequitable outcomes.
I'm wondering, I'm going to ping one of my classmates later on, because we're all right now at the dissertation proposal stage, and she's looking at community health benefits of hospitals. And I'm going to, for sure, if she's not on right now, send her today's segment so that
it's a testable hypothesis. She could tell me whether I'm right or wrong.
Yeah. Well, I'll let her let you know, in about a year and a half or so what her findings are, for sure. Yeah, let's talk a little bit in these last 10 minutes or so about, moving forward. We're going into a new administration. You were on hand as an advisor to Biden-Harris during the campaign. I'm wondering, what are the changes? What are some approaches that need to be advanced as we are looking to move into this next conversation of handling this crisis, right?
Well,
Especially
I think one of the aspects of this that's important is that healthcare has fundamentally been altered by the coronavirus. Not just because so many people didn't want to come in for a while, or and not just because there's so many patients, and we've realized what we need to handle a surge in very serious patients. I think, and not just because we've seen the heroism of so many. Doctors, nurses, everyone, people who clean the rooms, everyone, like total heroes to be able to stand up to this, even at times when people really aren't listening to them. And I'll put a recent article I wrote with one of my students in the chat just about that point. But fundamentally, the challenges of healthcare are changing. People are realizing they can get a lot done through telemedicine. They don't need to go to different visits. There are different rules that were in place that never really made sense. And now we were able to get rid of them, and people are going to be happier to keep them off the books. And so what kind of healthcare system do we build back? We know the healthcare system needs, money to be sustained. Turns out fee for service not only is bad for costs and bad for health outcomes, but it's not good for resilience either. The system kind of cracked, a lot of layoffs, all these problems. If you don't have, volume, then you can't pay for people. So I think it's an opportunity to reconstruct a more effective healthcare system in this country, and not, throwing out everything that we have by any stretch, but really thinking about being thoughtful about how to rebuild things and put in place different kinds of programs and incentives that really do a better job of aligning healthcare with public health.
Now, earlier in the conversation, you made the very astute comment that we've, essentially been here before as a country, where there have been these windows where great change could come, but it's not always manifest, right? So what are those elements that are going to help us keep up with, the imperative of the moment, which is, let's not throw away the baby with the bathwater. But to your point, telehealth works. There are other, fee for service is not resilient. Value-based care might be better, and there are other things, that we might need to hold on to. What is that mechanism that has to be maintained for us to, not just, completely do away with this moment or handle it in a way that's not sustainable?
That's a great question. And I wish I had the answer for it. When I get asked questions that I wish I had the specific answer for, sometimes I use a special trick I have on Zoom.
What is it?
Where I can freeze my screen so people think that I'm not, there I am. I'm
Wait,
back.
you have to teach me that.
Yeah, exactly. So it's good when students ask really hard questions.
Oh, great.
But I think that is the challenge. You put your finger on the challenge. That is the challenge that's facing this country. It's the challenge facing the new administration. How do we build back better, to use a phrase, a healthcare system that addresses some of its weaknesses? And, I think part of that's going to be federal policy. Part of that's going to be a growing recognition within the healthcare system itself about some of these issues, innovation, maybe changes to awards programs. It's our collective work, really, what you're talking about.
That's right, the collective work. And I don't know, so you were talking earlier about awareness building, right? Which I think is always a first and major step to coalition building, making sure that we are on the same page, or at least willing to show up and have hard, grapple with hard conversations. And that for a lot of people is the end of the transformation. It's the end of the revolution. Did we have a conversation about race? Did we have a conversation about social determinants of health? Did we have a conversation about trust and mistrust and vaccine development? Oh, okay, we did that. We checked that box. We're done. Right.
But really, that's the beginning. It's the beginning. Yes, it's the beginning. Well, I think it's very promising to see someone like Dr. Nunez-Smith. Is going to have a big role in the administration, and I know Dr. Murthy cares a lot about this, Dr. Walensky. So I think that, there are going to be some great people who are going to be involved in this. But I do think this is an area where everyone has a responsibility in their own world.
Yeah. We have a number of people who are on the call who are not necessarily, a number who are hospitalists and physicians and nurses, but then there are others who are in pharma, who are in policy. What can we say to some are students, what are some, maybe you'll put the freeze on with this question too. What are some final words for them that you have, Josh?
I would say that this has been a very distressing time for anybody who cares about health generally, about equity, about community health. We've just seen a devastating loss of life. As we're speaking, more than 3,000 people are dying every day in this country, and that is, not a burden being borne equally. It's really terrible. And underneath that, we can be frustrated by the harassment of healthcare and public health officials, people not listening. This is a very, very difficult moment. And I think it's okay to recognize that and to say, like, we are at a moment where, many things that we hoped had gone better haven't gone better. And yet it is a moment where we will have a chance to rebuild something different. And at every level, we should be thinking about how best to do that. And unfortunately, the work is not just to take care of patients. The work is to rebuild a system that makes something like this not happen again. And the one, I think positive thing to say is that history does have many examples of major changes that follow really catastrophic crises. And that is the opportunity that's there for us if we, can figure out a way to get there, and really will require people thinking about health and healthcare in different ways.
Yeah, powerful words there. And I actually want to invite Brandon Garrett back on the call, because there is a question from the audience in terms of, asking how can young people get involved, and there's no age specificity here, but it's just how can young people get into the new administration? How can we continue to promote equity and health justice? Brandon, I'm wondering if you can, given what Dr. Scharstein just shared with us, can you tell us a little bit about NMQF, what NMQF is doing to engage younger people or people who are newer in their profession?
Yeah, so when I think right before you got to Congresswoman Kelly's office, Mia, one thing we were trying to do is to make sure that we had more younger people involved, and young, that as we defined it was just at the time below, like 40 and below, that people just, sort of been in their careers for a few years, just got out of school, graduate school or whatnot. So we started a program called the Top 40 Under 40 Leaders and Minority Health Leaders. So that's one thing we've done. And I think over time, that has sort of made our conference and the folks that we work with, we sort of added to, right? We didn't kick anybody out, but we added to, and we added more younger voices and more students and whatnot. And so that's one thing that we've done. Additionally, as far as working with the administration, one of the good things is that President-elect Biden, actually, we've worked with him on a couple of occasions. One, we were able to do the Biden Cancer Initiative, and NMQF handled the data. And additionally, he worked with us on the summit, the annual summit on health disparities last year, he and his team. So we have a good contact with the administration, and we've actually been talking to them about making sure they have a diverse group of folks that work specifically in the HHS space, the Department of HHS, but then all across. So we've been working with their transition team, sort of recommending folks for the administration that we think would sort of help sort of answer a lot of the problems or the questions that you guys discussed today. And we're hoping that they choose some of those folks.
Yeah, so basically stay involved with NMQF, keep coming to the Friday panels. And if nothing else, you will certainly walk away with more than what you came in with. And with that, we're really grateful for Dr. Joshua Sharfstein, who joined us today from all his myriad positions. And we look forward to staying in touch with you. So thank you so much, Josh.
Fantastic. Thanks for having me.
Absolutely. I'm going to order your books as well. Thank you so much.
Okay, bye-bye.
Have a good one.
All right, bye, folks.